Hi, good morning.
Good morning.
And I see the printed copy of what I said last time. Did anybody have any questions on the floor? No, okay. So this will be let's assume our patient is NPO, which is almost everybody post-operatively. So we need to then mentally know, or actually a scientific formula, how to calculate their fluid requirements. So good. So your fluid requirement are exactly the same as your calorie requirements. So that's a simple mechanism to understand. A rough formula to calculate the next 24-hour fluid requirement is weight of the person in kilograms multiplied by 40 on average. So let's assume average patient is 70 kilograms. I'm just going to take 70 kilograms. So if you multiply it by 40, that comes to be 2,800. So that comes to be roughly 125 milliliters an hour. So if you really want to be precise, then we can calculate actual weight, the fluid requirements. So the first 10 kilos multiplied by 100 milliliter, okay? So that comes to be 1,000. So the next 5 kilos, actually 10 kilos, is 50 milliliter. So that will come 500. For the next 50 kilos, it is 30 milliliter. So that comes to be 1,500. So if you add that up, it comes to be 3,000. So this is for if you really want to calculate, mostly for children, their weight and their for adults, this is a rough formula. So the calorie requirements are exactly the same. So our dietitian and our TPN people underestimate our calorie requirements. So they are actually always, your every calorie requirement on the flow report, 1,800 to 2,000. That's just a basic requirement, just to survive. So if you see most of our patients on TPN don't gain weight because we're not giving them enough. Yeah. So you just can't fight with them. When I used to do TPN for the whole hospital, that was completely different. That was 40 years ago, okay? So then, so roughly 3,000 or 2,500. If you calculate by an hour basis, it will be 100 milliliter in an hour or 125. So that should be your average transfusion of the patient for the fluids only.
Okay.
So how you calculate actual weight of the person, okay? It's a little different than male and a female. So it will be for a male, 5 feet, first 5 feet, 110 pounds. Okay, that's to just start with. And the next, every inch is multiplied by 5 pounds. So let's assume average male patient is 5 feet 10 inches. So that comes to be 110, 10 inches 50, 160 pounds. So for a female, so the first 5 feet is 100 and the rest remain the same, okay? So average female is like 5'6", 5'7". So multiplied 100 plus 35. So that's 135. pounds. It's funny thing is everything else we do kilograms, but when we weigh ourselves in pounds. Then you have to convert in kilograms divided by 2.2. Okay. So if somebody is obese, their fluid requirements doesn't change because we calculate on their average ideal weight. So for a man, ideal weight is calculated when they're 18 years of age. For the female, the same way. Yeah. So if you calculate 160 divided by 2.2, it comes to be 70 kilograms. That's how the figure was arrived on average 70. And the female 135 pound divided by 2.2 is between 50 and 60. So your requirement is slightly less than men, but it's more or less comes to be the same, between 2,500 to 3,000 milliliter fluids. So if then we'll discuss some other time why we change the formulas and why we give more fluid, why we get less fluid in certain condition. I think when I discuss with you guys the intestinal obstruction, that's when I will also mention why the fluid requirements are different. Okay. For average normal person, these are the requirements. Okay, so then you're going to ask me, well, what kind of fluid to give? The fluids are the variety like a D5.5 or a normal saline or D5.5 with a potassium. Why we give those kind of fluids? That depends on your requirement of your electrolytes. So what is the daily requirement of sodium?
I know the normal number, but the daily requirement.
That's what I'm saying. What is the normal requirements of sodium? So that will depend on what fluid we get. Okay, let's do sodium. Okay. Cardiologist wants to have you 2 grams of sodium, but that's a very low sodium. That put a strains on your kidney. Average requirement for a normal person was 6 grams of sodium. Okay. So if you put 6 grams of sodium in a liter of fluid, what that becomes? There you go. That's why normal saline, it's a 6 grams of sodium in 1,000 cc of fluid. So then we calculate it to milliequivalents of sodium is between 144 to 150 milliequivalents. Okay. So that's why the 1 sodium bottle is adequate for the sodium intake. You will say, well, why we give them 3 liters of normal saline?
Yeah.
We don't give 3 liters of normal saline. I'll come to that.
Okay.
Because we are giving half normal saline with the dextrose with the potassium.
Okay.
Yeah.
Okay.
So we are still giving we'll come to the other fluids. So then what is the potassium requirements? How much?
Is it 3.5 to 5?
Say it again?
3.5 to 5?
No, that's your electrolyte.
Electrolyte now.
Oh, yeah. Oh,
Your
that's
requirement.
Oh, my,
For
the requirement of
requirements,
potassium.
So then when you call me, Dr. Syed, you ordered too much potassium in IV.
20 okay is usually what it is in a
No, but that's
yeah,
20 in
but
a liter.
intake, yeah. Oh, yeah. I'm not sure how much.
It is 60 to 80 milliequivalents of potassium,
Okay.
the daily requirements.
Okay.
So that's why when we add 20K into 1 liter bottle,
Mm-hmm.
and 3 bottles, that comes to be 60 milliequivalents.
Okay.
Yeah. In a certain condition, then I'll discuss that why we change the IV formulas. Okay. And then there are other one we normally don't give them. That's the calcium. That's a magnesium. That's usually important when you're giving TPNs.
Okay.
Because in a normal person, your magnesium level goes very quickly down. In 2 or 3 days, you're completely hypomagnesiemic. So that's why TPN people need a magnesium. We normally don't give on a regular fluids. Okay. So why we give what kind of fluid we have, what we give to the patient. One is the normal saline, right?
Yeah, lactate expanded.
Lactate is Ringer.
She said D5 and then
D5 half normal.
D5 half.
How's the say?
Half normal saline. What else?
It's D5 in water too.
D5 in water. Okay, what else?
Very rarely we give that 0.20 of say we
One.
were, yeah, the 2% said,
Normal saline with 20,
No.
okay?
Yeah, but that's
No, no.
electrolytes. Okay. All right.
Oh,
So then the other one, D5 1/3 normal saline, D5 1/4 normal saline. Those are for
oh, that's it.
1/4 is the pediatrics. We don't have a pediatrics, so we don't give it. Okay. So these are the fluid. And the normal saline we usually give people who needs the volume, very quick resuscitation, because there's no sugar into it. So we quickly give them a sodium so they can expand the intravascular volume. Regularly, Ringer's lactate is little different. The sodium is 132 instead of 154, but has a lactate.
Okay.
And the lactate also has a little potassium. So diabetic patient, instead of giving him D5 fluids, you can give them lactate fluids. The lactate get converted into sugar later on. So have the little better control of sugar. So in the operating room, usually they are given, but theoretically, really, there's no difference between lactate solution and between normal, except when you have a renal failure.
Right.
Then you don't want to give them extra potassium. The potassium is very high. D5 half normal saline, and so if you purely give D5W, that's the acidotic fluid, because their osmolarity is quite low. So to add sodium into it became a normal isotonic. That's why this dextro and sodium fluids comes. So on average in our hospital, it's the D5.5 with the potassium. So that's the fluid again. Ideally, if you don't want to overload the sodium, when we were resident, we used to give D1/3 normal saline with the sugar and potassium. So if you take 1/3, 1/3, 1/3, so we were giving actually one saline bottle in 24 hours, your regular requirement. For the human body, that can easily maintain your sodium, your potassium, your electrolytes, if you give adequate on each day. So it will be 3000 cc of fluid, whether you give on a heart failure patient, you don't want to give normal saline, because then you're going to overload them with the fluid. Lactated Ringer is the same way. So ideal is D5.5 or D1/3 normal saline with the potassium. So those are your requirements. Okay. In certain situations, let's assume the patient now has a nasogastric tube. And they are, say, 1 liter. Okay. We won't go further to 2 or 3 liters. So when you have a nasogastric tube which drain 1 liter of fluid, what does that entail? What is the composition of nasogastric fluid, gastric fluid aspiration?
Acid? No.
It's acid,
Acid, okay.
so it has to be chlorides, right?
Right, okay.
Okay. Hydrochloric acid is mostly chlorides, hydrogen and chlorides. What else? They have sodium, they
Okay.
have lactose, they have potassium.
Mhm.
So their requirement of sodium, potassium, and chloride is going to be much higher. So the way you calculate the fluid requirements on that patient, particular patient, your daily requirements plus your NG output in electrolytes forms. So the 1 liter of saline, 1 liter of nasogastric fluid has about 40 milliequivalents of potassium. So their potassium has to be replaced plus what they need.
And so that's why we have always that 20 MEQ IV fluids.
But 20 MEQ is just a basic
Just a
requirement.
little required, so we
Yeah.
have to do an additional.
You have to do more.
Okay.
Okay, so those are the special occasions, like how you replace potassium. You replace potassium in the IVs, which is a 20 milliequivalents. Let's assume somebody's potassium is 2.8,
Oh.
okay? But they cannot take PO. They have an NG tube. So NG tube is draining 40 milliequivalents of potassium plus 60 their requirements. Now you have to give them 100 milliequivalents of potassium. But you have a limit how much potassium you can put in the IVs. Okay? So you can put like a 40 in each liter. But if you start to give more than 40, then they need to be monitored. Yeah. Then they need the cardiac monitor on that. So you can't give them a bolus. You can give them a saline bolus, but you can't give them a potassium bolus.
Okay.
Yeah. Because then they will have cardiac arrhythmias and cardiac arrest. Maximum you can give in an hour potassium is only 20 milliequivalents.
Okay.
Yeah. So you can't give them a bolus. You have to calibrate their 24-hour requirements. Same thing for the sodium. The sodium will become low if you don't replace them. If you give them, say, D5 and W, your sodium is not going to be replaced.
Right.
So you have to replace them. Sodium, in certain situations, like patients who are diabetic, say sugar is 500, 400. What is their sodium is going to be?
It's gonna be low.
And why? I know it is low. So there is actually a formula for every 100 blood sugar, your sodium goes about 4 milliequivalents low. So it's just a compensation of the body, so it's artificially low. Your potassium goes up because it's coming out of the cells, sodium goes into the cells, and the sugar goes up. So in that situation, the treatment is not sodium replacement. Treatment is the sugar control. As you give them insulin, as their blood sugar goes down, their sodium goes up and their potassium comes down.
So we usually replace the sodium,
Yeah,
but
yeah.
instead of controlling the blood sugar.
Yeah. So it's just the opposite. Same thing with the renal failure patient. Their potassium is usually high.
Yeah.
It's very high. If they are not dialyzed, they can go to 6, sometimes 7. So they need to be dialyzed to bring their potassium down, not restrict just this potassium. Combination of both. Any questions so far? So the 3 things we're going to take it. Your daily requirements of fluid is between 2,500 to 3,000 on every patient on the floor. Your daily potassium requirements 60 to 80 milliequivalents. Your sodium requirements 1 bottle of saline, which is 144 milliequivalents of sodium or 6 grams of sodium. But we are not talking about eating but food. Your magnesium, calcium usually doesn't go, but in some people who are hypocalcemic, then the best way to correct would be to put the calcium chloride. There's also calcium gluconate. Calcium gluconate takes longer to replace calcium than calcium chloride. But there's a special TPN requirements. Okay, let's, when you are giving sugar, D5.5 or dextro 5%, and people usually worry about it in a diabetic patient, that's a lot of sugar, right? But guess what?
It's not.
It's not.
Oh. We thought it was a lot.
Okay, D5,
Yeah.
that means 5% of the sugar, right? So in 1 liter, it's 50 grams of sugar, right? How many calories are there?
50.
No.
Oh.
1 gram of sugar gives you 4 calories,
Okay, oh, okay.
okay? So 50 grams of sugar gives you 200 calories. So even if you give 3 bottles, you only giving them 600 calories.
Okay.
So that's,
It's
patient is
nothing.
NPO.
Yeah, that's.
So that's not, you're starving people when you give D5. Yeah.
Yeah.
So their sugar is not going to change much.
So then we should not be concerned when
Well, we should, let's assume their sugar was 300.
Okay.
Then you can't give them D5 because you're increased in sugar level. But on an average person, we don't have to worry because we are really starving them. D5 is very little sugar. So how many calories each gram of protein? Sugar and proteins have the same.
All the same.
Yeah. 1 gram of protein, 5 calories, 1 gram of sugar, 4 calories, 4 calories. 1 gram of fat, you double it.
Oh.
Yeah.
The fat we double.
So actually it's a 9 calories to a fat.
Oh, okay.
So when people are getting TPN, the 50 grams of fat is 450 calories compared to 400 of sugar. So it's double the calories. So if you see their formula in a TPN is D550, then proteins is another 8%. You calculate according to the 8.5 by your 70 grams of requirement. That's how they calculate the fluid. And your fat requirements, your fluid will be down number-wise. Let us see any other questions. I think more or less that's the function today.
But I have
Yeah.
a question.
If you keep on just daily basis calculating your mind, then you don't have to think twice.
Okay.
Yeah.
So then I have I
Yeah.
guess a general question. So then when we have a patient an NPO,
Yeah.
so the fluid should be at least the rate should be at least 100 to 125?
Yeah, except cardiac patients.
Accept that.
Or this elderly patient who's frail, congestive heart failure, and their weight is only 40 kilograms, then they have to be adjusted. But on an average person, surgical patient, you need it between 2,000 to 3,000 fluids. Yeah. So when you guys run out of the IVs in the middle of the night after 1 liter, and we say, well, we don't need to give because you don't drink. And one of the message one time nurses gave to the patient, well, why you don't drink during the night? Your IVs came out, we are not going to start it.
They still need it though.
Because they are NPO
Yeah, exactly.
and they had surgery.
Yeah.
And so they haven't had fluid the day before, they've been NPO after midnight.
Right.
By the time patient comes to the operating room, say 8 in the morning, they are 8 hours, they are not drinking anything. You and I all get up and we have a cup of coffee or glass of water. So we get fluid immediately, but they haven't had a fluid. Also, in the operating room, when we used to do open surgery, the fluid requirement was completely different when you do laparoscopic surgery. In an open patient, when you're opening the abdomen, and you say you take an hour to operate, you lose 1,000 milliliter of fluid just from evaporation that quickly. When you do laparoscopically, you're not losing any. So their intraoperative, if you see their total fluid intake in the operating room for colon case, they're usually giving like 800, 900 of fluid. They used to be 2 liter, 2.5 liters of fluid.
Oh, wow.
So you are under infused these days. So when they come to the floor, you see why their pressure is low,
Mhm.
that they haven't gotten enough fluid in the operating room. So that's why it is very important. These patients needs to have a proper fluid replacement in the next 24 hours.
Mhm.
And then we adjust the next day depending whether they start to have liquids or they are not taking any liquid. If they remain NPO, their requirements are going to be the same. Yeah. And the first post-op day 1, the next day they need to have at least CBC electrolytes. Don't have to have a CMP, but electrolytes.
Yeah.
So we can see what their potassium is, what their sodium is, what is the requirement for the next 24 hours. They made adequate urine or they didn't make adequate urine.
Mhm.
So to replace accordingly. So when we are making rounds, and you might think that we just come and look at the wound and
No.
that's so every one of us what we call a computer rounds. So in the morning before I come, I see all my patients, their electrolytes, their vital signs, their output. So the only thing I need to see now how my patient clinically they look,
Mhm.
whether they have temperature or their wound is inflamed or not, or they have bowel sounds or not, they are distended, how comfortable they are their legs swollen, are their hands swollen.
Mhm.
So clinically I'm looking, but then I already know what the laboratory workup was.
Okay.
So that's how you make the rounds.
Oh.
You make rounds on a complete patient, what they look like, what their electrolytes were, what their vital signs were, what their ionos were.
And when should we be concerned about when we have a JP drained?
That's the next week.
Or next week?
Dr. Ko is the duty that not the next week, the week after.
16th.
She's going to do with an NG tube and drains.
Okay.
Yeah. So what I will suggest that you will get an NG tube, any NG tube. Actually, there are 2 varieties.
Okay.
One is with the simple connection, and one is the weird
Oh,
looking.
yes.
Yeah. So every one of you need to know
Yeah.
how to function that.
Mhm.
Okay. So the history of NG tube is very, very long. We used to have just a rubber tubes. There was no vent. So that didn't work out because they used to get clogged. There is no vent. All the NG tubes these days are called vented tubes. The blue vent,
Mhm.
the purpose of that is the air to go in, fluid to come out. And the other one is the same way. The only tube doesn't have a vent is the iris tube for the feeding purposes.
Okay.
Yeah, because we are just feeding them,
Mhm.
and that's why we have to flush them
Okay.
so they don't get clotted. Same thing we have to flush. When you flush the NG tube, you flush the blue part and you flush the regular part. So if you see the bile coming out of the tube on the blue part, what the nurses do, take the white thing out, put the other way so it doesn't leak. Guess what you guys are doing?
It's
It's
clogging.
closing.
But you're converting that into closed system. And the reason the tube is leaking out because it's not functioning, it's plugged. So it's leaking out that way. But I'm gonna let Dr. Ko decide because and the only other on an NG tube, if you look at the pamphlet,
Mhm.
it says on it, high medium suction. But we always put low medium suction. So it is us who also make the mistake. Because those orders were probably pre-populated long time ago.
Okay.
It should, my simple rule is
Medium.
between yellow and red.
Yeah, I think that is.
Yeah, simple.
Medium is a bit.
It's a medium
Yeah.
section. Any questions? Any question from the last things? No? So 3000 cc of fluid roughly, total 3000 calories, that's your average requirements, but we don't give them. your 1 bottle of saline, your sodium requirements, your 20 milliequivalents in each liter of fluid is your potassium requirements, and all other electrolytes we adjust. So when we call and give you some orders which are not suitable for the patient, then you can immediately say, well, doctor, that's not, we shouldn't be doing it. Yeah. All right.
Thank
you.
So Dr.
Thank you.
Cole will be the next victim.
Okay.
And so my